doesn't matter over there. Gilby signed that. Yay. Done. On my calendar.
Something in front of me, I decided I didn't really read it.
Say my name?
Hi, are you okay? I had to run across the parking lot. Did you sprint over here? I sprinted. Yeah, when I filmed it on you, it was kind of sauna-ish. Yeah, right? Yeah. No. What? There's a lady here who works with him. And she said he's on. Yeah. Do we have the presentation? Yeah. Okay, sorry. That's what I got it. Yeah, I know. I have to search. Marlene and Mayor en route, she said. I know, it's weird. We will not melt. We will not melt. We will. Archie's rushing back. You can start when she gets there. She'll hit the button when she sits down.
He's ready.
Oh, you're ready.
Yeah, we got it.
You got it. Go for it. You've got quorum.
All right, then. In that case, we're going to go ahead and call the meeting on Monday, September 11th, 2023 to order. And before we do the roll call, what I would do is like us to take a moment and reflect on the 9/11 event that took place and keep, say a quick prayer for those who perished in the attack, and then those who have gone on for because of other health-related matters based on that. So if we can just take just a few seconds here to do that. Okay, thank you very much. All right, go ahead and call the roll, please.
Sure. Mayor John Minto.
I'm here.
City Manager Marlene Best.
Present.
Captain McNeil.
Here.
Lieutenant Galvey.
Here.
Jacob Donnan.
Here.
Mike Olander.
Here.
Kristen Dare.
Here.
David Shorey.
Present.
Bonnie Baranoff. Dr. Foreman.
Here.
Steve Stellman.
Here.
Jeanette McLaughlin.
Here.
Mike Aiken. You have quorum, sir.
Thank you very much. And let's see, let's move on to the approval of the August 14th, 2023 regular meeting minutes and the additions, corrections, or deletions to be made. And not seeing any. Do I have a motion to approve?
So moved.
Motion by David. Says here, second? Second by Dr. Foreman. Okay, please call the vote roll.
Sorry, sir. Mayor Minto,
Aye.
City Manager,
Aye.
Captain McNeil,
Aye.
Mike Orlander,
Aye.
Kristen Dare,
Aye.
David Shorey,
Aye.
Lonnie Baranoff,
Aye.
Dr. Foreman,
Aye.
Steve Stellman,
Aye.
Danette McLaughlin,
Yep.
Mike Aiken. Motion passes.
Great, thank you very much. Let's see, today we're going to have a presentation from the County of San Diego Behavioral, I missed 3. You know, it's a bad day when you put a new razor in your blade and you nick yourself first thing and you bleed for about half an hour. I think everybody can relate to that, so you know, it's a bad day. So let's go with item number 3, which is an update on Neighborhood Watch and crime prevention. And thank you for keeping me on track here, David. I appreciate it. Here, you want to do this?
All right, good afternoon, everyone. A few weeks ago, we were able to attend the first annual Pathways Church X-Fest event, which was a great success. The turnout was wonderful. We also brought out our newest SED Bearcat. For those of you that came, probably got to see that. It's our new armored vehicle. Last week, we conducted a DUI checkpoint in the city here. We had 762 vehicles come through. 46 vehicles were sent off to secondary inspection. 2 arrests were made, and other citations were issued that night as well. This Saturday, you'll also be able to find us at the Santee Historical Society at their safety event they're having.
Great. Lieutenant, Captain, anything to add? Okay, thank you. All right, let's go to number 4 now. And that is presentation, County of San Diego Behavioral Health Services, Director Luke Berman. Welcome.
Thank you.
You're welcome.
Thank you for, gosh, I feel so welcome. I feel amplified even.
We're a lot more casual here than, other kind of meetings, so.
Oh, that's good. Yeah, they can get pretty stuffy. So I'm happy
What are
to
you
be.
trying to say?
I mean, the county ones can get stuffy.
Nice.
Glad to be here with you all. We want to talk with you today some about one of the important initiatives that we are developing in the world of behavioral health services. We do a lot of stuff across the Behavioral Health Services Department. We are, just by way of orientation, we are the health plan for everybody who is on public insurance, everybody who has Medi-Cal and has either a serious mental illness or substance use disorder. We function as the health plan for those folks, like other commercial health plans do for their membership. We just have generally a larger membership, and then it's kind of responsive to state policy in different ways, and of course to need in different ways, right? So when need generally goes up, then there is more that we as a health plan need to do, and that's been a real sort of dynamic recently, especially in the wake of the pandemic. Rates of psychological distress across the community, across the county of San Diego, but more broadly across the nation and across age cohorts have gone up like 200%. And rates of more serious psychological despair leading to major depression have gone up 500% since the pandemic. So we're in a state of really increased need, which we as a department need to be responsive to. The way generally that we work and the way that we are sort of oriented to kind of shape behavioral health services across the county is reflected in this graph that I show often when I make presentations about what we do. What sort of has been the current state is reflected in the upside down pyramid on the left-hand side, where you see the sort of largest territory covered in orange there under crisis services. And we have been, behavioral health services really across the country has been oriented around crisis response very disproportionately. and not sufficiently oriented around upstream preventive work, around making sure that people stay well and don't get into crises in the first place. That's kind of been like a thing that's true of healthcare generally, right? We've got all these hospitals that are built as stacked towers. Those are acute care hospitals. They're meant to deal with people in acute need, people in states of physical healthcare crisis. Most of what we face as a population in terms of health need is not crisis care. It's ongoing chronic illness care. So healthcare generally is in this weird place where it's trying to shift away from a crisis orientation. And that's very true of behavioral health, except I would say behavioral health is a little bit behind the rest because it's been so siloed. So we're kind of really emphatic about the significance of shifting from a crisis-oriented system of care to one that's more oriented around prevention and upstream intervention. And so this juxtaposition of these triangles is meant to reflect that. I'm assuming that there's like some time for Q&A and stuff like that, right? Okay, great. One of the key bodies of work that we're engaged in that's really meant to, to begin helping us actually shift the proportional investments that we're making and sort of the prevailing experiences that people have who need behavioral health care is in this domain of work that we call crisis and diversionary services, right? We want to shift away from crisis. So one of the areas we really need to focus on is rebuilding the crisis system response that we have in behavioral health. Because traditionally, what's happened, and this is probably will feel like, familiar because it's so much in the kind of public narrative about what happens. People go to emergency departments or to jails when they're in behavioral health crisis. And that depends some on the jurisdiction, it depends some on the demographics of the folks involved statistically. But that's generally what happens. A call to 911 is made. Usually it's law enforcement, which is why this is a very useful committee for me to be speaking with. It's law enforcement that usually shows up. And then the disposition is that a person is picked up, usually after some not great series of events, which are incredibly risk-laden, right? I think you probably are aware people with serious mental illness are 16 times more likely than those with not to be shot by law enforcement. And we know that those encounters are very, very risky for all parties involved. But that's traditionally what has happened. Emergency departments, that's the best case scenario, right? If we're talking about a jail or an emergency department, we probably would prefer an emergency department to taking somebody who's floridly psychotic to a jail, right? And jails are not resourced generally to be able to identify and to manage that kind of thing expediently. But emergency departments are, in fact, pretty awful places for people with serious mental illness to wind up. They are not designed to address that kind of need. And I'm imagining, show of hands, anybody been to an emergency department, right? Most people have had the great fortune of at some point or another being in an emergency department. And they are chaotic places, right? There's lots of buzzing and moving around and hustle and bustle. They're very often very crowded. And they're staffed primarily with people who have an acute care orientation. They are trained to do work in a very specific way, which is to see what's going on, triage, right, as quickly as possible, what's going on, identify absolute must-haves to keep people breathing in a current moment, and then to get them somewhere else as quickly as possible for some additional or ongoing care. The most important metric that emergency departments use to measure how effective they are is throughput. Right, and for anybody who works in healthcare, right, that will be very familiar. EDs are doing well when they've got high throughput. When people who come in get out real fast. It's sort of like you could make an analogy to a busy restaurant, right? You want to turn tables as fast as you can, and there's a little bit of sort of economics in that, in fact, that is directly analogous to restaurants turning tables. Emergency departments are designed to, charge money for procedures that they do better with when they do them fast and then get people out. If you come in there with a behavioral health condition and this is really true of virtually all behavioral health conditions, so which includes mental illness, like major depressive disorder, mood disorders, depression, anxiety, but also, and more importantly, I would say, for emergency department spaces, psychosis, where you are disconnected from reality. You come into an emergency department with psychosis, there is nothing that an emergency department physician can do to relatively immediately stabilize you. There's nothing that they can do. So what they wind up doing is putting you in a gurney. Sometimes if you're brought there in a 5150, right, you will be in some form or fashion restrained in a gurney. If you've got substance use disorder, same thing. There's really nothing that an emergency department can do well with somebody who's got substance use disorder. Right? Very often we see showing up in emergency departments combinations of people with substance use disorder and some kind of psychosis, right? And this is a thing that we know, that the disproportionate rates of people with psychotic illness have substance use disorder. These two things, come, unfortunately, in tandem very often. And those presenting conditions, which I would just say are some of the most common to come into emergency departments. If you look at ED data, show me the most common category of presenting condition in an emergency department. It's going to be alcohol related. And a lot of those are because people get injuries when they're drunk, when they're intoxicated. But a lot of it is because people are just, too frankly intoxicated to function, and they have substance use disorder. The most common category of conditions to show up at emergency departments are not well equipped to address. And it leads to this kind of like cycle that's really impossible because these folks come into emergency departments can't deal with them, so they just dispose them as quickly as they can, either to an inpatient setting where usually folks, aren't going to do best, because very often the emergency department will send them to an inpatient setting when they don't really need to be in that intensive a place. But it's just the emergency department doesn't know what else to do with them. So if there's an open bed, for God's sakes, throughput, let's get them out of here and get them into that bed. What happens more frequently is nothing, a whole lot of nothing therapeutically. Folks will sit for hours, sometimes days, in gurneys in emergency departments, and then they'll ultimately be released to the street. So to try to intervene in what has been a very, very long-standing and problematic dynamic with emergency departments, we've built this network, regionally distributed, of something called crisis stabilization units. And these are most, I think, simply understood as alternatives to emergency departments. And we've got 6 of them established so far, and we're presenting to you today on plans for the 7th of those, which we gather would be particularly relevant for you all and your constituents and co-community members, because it's going to be sited in El Cajon, so it's in East County. I think maybe still, and kind of weirdly, a little bit surprising to folks that El Cajon is the site of significant need for behavioral. I mean, I think, in recent days, the discourse about homelessness in El Cajon has kind of caught some fire, right? So there's been a lot of tense talk about homelessness in El Cajon, and so I think that's maybe changed people's perceptions. But it shows up in our population health data reflecting need relatively prominently. And then it also shows up in our data reflecting density of people enrolled in public insurance. People on Medi-Cal also highly. So this makes sense as a place, we think, for us to establish the next of our crisis stabilization units as we continue to build these out. Now, what are these things? Talk about that for a little bit. As I mentioned, they are, I think, best thought about as alternatives to emergency departments. They are places that are suitable for 5150 transport, right? That's kind of like a first question. Are these places where law enforcement can meaningfully take people in states of mental health crisis? Absolutely. These are just about the ideal places. The only folks who wouldn't be better served in a CSU, crisis stabilization unit, than in something like an emergency department are people with comorbid physical conditions, or what we would call medical complexity. Those folks will sometimes show up at a CSU. So CSU is still, like better than many alternatives as a transport location. And then folks would be transported from those settings to an emergency department. When law enforcement is picking somebody up on a 5150, for example, and they can see or discern that there's some medical complexity, they would likely take them directly to an emergency department instead of a CSU. But really, these are settings for people with great acuity of need. They are designed, and you can see in the picture here, and I would actually say this picture looks lovely, doesn't it? Looks like a showroom for fancy furniture. But this doesn't even do justice. It doesn't even come close to doing justice to what the space that this is a photograph of actually feels like. This is up in Oceanside. This is the crisis stabilization unit that we built in Oceanside into a building that is the North Coast Live Well Health Center, so county-owned property. And it sounds always, I feel like I'm being hyperbolic when I talk about this, but I'm not kidding and I'm not exaggerating. It feels like a day spa, this place does. It feels like places I used to spend hundreds of dollars for birthday presents to send my wife when we were living in New York. It's lovely. It's not what you think of as a space where you would be doing, kind of emergent stabilization work with somebody with psychosis, with somebody who's got schizophrenia. It doesn't have beds. You can see these green chairs. We call them recliners, and we describe the sort of units of volume in crisis stabilization centers. We describe that volume with reference to the recliners rather than to beds. So you'll hear people when they talk about hospitals, they'll talk about, well, we're a 100-bed, 200, 300-bed hospital, or we're a 30-bay emergency department. Oceanside is described as a 12-recliner CSU. So it's got 12 of these lazy boy chairs in it. And they are sitting in a kind of common open space that conforms to what we call the living room model. And it really feels like a living room, like a place you would just want to hang out. It's a beautiful place. It's got this space in Oceanside has a green wall, a living wall. It's got 2 courtyards with burbling fountains and stuff. It's really, really beautiful and really therapeutic space to be in, certainly relative to what folks are accustomed to thinking about. One of the sort of key tenets of this living room model idea is that you're not bound to a bed or even a particular way of sitting in or inhabiting a chair. You're really given some latitude to figure out how to exist in this space on your own a bit. So people sometimes will just recline in the chairs that are there. Sometimes people will lie down right next to the chairs. People will, kind of move around the space at very much their own volition, moving into and out of courtyards and things like that. It's entirely locked, however, right? So it's this beautiful spa-like space that is a locked facility, just like other ligature-resistant psychiatric facilities are. Ligature resistance, a fancy phrase meaning that we've taken everything out of that space that a person could use to kill themselves. That's kind of it's an architectural standard that the most acute spaces for psychiatric care need to adhere to. This is what we call a community-based crisis stabilization unit. Some of these that we built, if I go back a slide, go back 2 slides. Some of these that we built are hospital-affiliated and hospital-sited. So the one in Escondido, what we call Palomar CSU, that's at the Palomar Hospital, it's Palomar Health System Hospital in Escondido. It's just adjacent to the big tower, for those of you who've been up there. It's hospital-sited. The Paradise Valley Bayview CSU in South County, that's hospital-sited. The San Diego County Psych Hospital, EPU, that's another CSU, it's hospital-sited. The 2 that we've most recently built up in North County, at the Live Well Health Center in Oceanside, and then the North Coastal Community-based CSU in Vista, and And what will be the model for the East Region CSU is that these are community-based CSUs, not connected to any hospital. And that has huge consequence. Can I ask really quick, how long do y'all expect me to talk? Because I'll just go and go.
We got until about 3.
Oh, okay, good.
We kick you out at 25 after.
Oh, you do? 25 after 3 or 25 after 2? You're going to be here till 3. I'm gone. Is that what you're saying? No.
You're doing good.
Okay, appreciate that. So these are community-based CSUs, and this has very material, like instrumental significance for how they're used, because hospital-based CSUs are subject to this policy called EMTALA, and that is a federal policy that mandates that a party depositing a person at a site that is governed by this policy must stay there with the person they are depositing until they've had an initial evaluation, right? So a police officer, in most cases, is dropping somebody off at an EMTALA-governed place, and then they got to stay there a long time. For those of you who work in law enforcement, you probably have done this many, many times. You probably had multiple days of your work lives ruined by this kind of experience. You've had your productivity doing the work that you signed up for this profession to do diminish significantly by spending all those hours doing that other thing. So one of the really beautiful things about community-based CSUs, they are not subject to EMTALA policy. So drop-off can happen very fast. Within 5 minutes, in fact, which is almost like, you talk to law enforcement folks who are not familiar with this experience, it almost seems unbelievable that it could be that different. But it's really true. No EMTALA, the drop-off is minutes. One of the ways that sort of, works clinically, therapeutically, is that CSUs lean very much into a relational model of care. So a thing about emergency departments also with all this kind of throughput and emphasis on acute care is that they're very transactional kind of care places, right? Like, what do you need? Let me get you what you need. Let me just get you right over there. That also does not work in the world of behavioral health. People who are suffering with behavioral health conditions need to feel like they're being related to. They need to feel like they're being engaged with in order to be receptive to care. So one of the great things about CSUs is they are fortified with a lot of peer support providers. So there's, oversight that is prescriber level, right? So NP, psychiatrist, but the workforce that maybe is most critical to how people actually doing are peer support providers who work in these settings and are expert at doing that kind of identification, really, and relationship building instantaneously as people are dropped off. They are engaged, like, kind of first and foremost with a peer support provider. And again, this is another thing, it's sort of hard to imagine being true, but that's so significant to effective de-escalation with people who are being dropped off, that the drop-offs tend to be very smooth. Relatively incident-free drop-offs at CSUs. Turn back. They are also, these spaces are also accessible via walk-up. So it's a kind of hybrid, right? I would say, I have numbers on these. I can get you guys data as much as you would want it. I don't have it all with me, but I can get it to you on the back end of this presentation. We have, I think, proportionately more drop-offs, and most of those drop-offs are drop-offs through law enforcement than we do through walk-ups. And walk-up is a metaphor. You can drive to a CSU, and we would still call it a walk-up if it's a non-law enforcement or first responder transport. It's a smaller percentage of the total presentations are these kind of non-transport, but it's significant that there is a way to access care there just for people in the community. And there are 2 separate entrances, one that's devoted to law enforcement and first responder, and the other that is devoted to people who are just walking out. And it feels that kind of walk-in path into the setting feels much more like a sort of traditional clinic entrance does with a waiting room where people are greeted, again, immediately by peers, and then they are brought into a clinical assessment room and then transitioned into the living room space. Now, I'm sure you have questions about that, but I'm going to move on. One of the really extra cool things about what we're doing with this El Cajon CSU, and we call it a CSU and RBC, is that we're building it in immediate adjacency to a substance use focused service that we call the RBC, Recovery Bridge Center, that can be thought of as a sobering service, if people are familiar with what a sobering service is, right? So it's not like a super robust detox program where you gotta like work really hard to get a person to be convinced to go into a detox program. This is a very low threshold service meant for people who are actively intoxicated, meant as law enforcement drop-off exclusively at this point. And it's really an observational service meant to give people time to clear their intoxications, and then ideally to be navigated to some kind of ongoing care. So there are sobering services, and they're spread across the country. Very famously in Houston, Texas, has a very, very kind of innovative sobering service model. And we've got some sobering service here in the county, in the city of San Diego. That is not paired with on-site addiction treatment. It's really, nurse-observed intoxication clearance, and then folks are on their own. What we're doing with this, in this setting, is establishing that low-threshold observational sobering service, and then stationing a light-touch addiction treatment capacity just adjacent to it in the same building. So that'll give us a much more, I think, robust opportunity to actually like engage with people coming out of periods of intoxication and get them in those moments of, I think, what we can anticipate will likely be greater, interest in engaging in care. We can navigate them right into treatment right at that moment. And it's really significant that these two things are in the same space. They're just adjacent to one another, same building. They will be operated by the same entity. So these will not be county run. We are procuring these, and so they will be run through contractors. But our hope is that over time we will have opportunities to better and better coordinate how these two things operate, so that ideally they really are able to function, as sort of one relatively seamless service. An issue with crisis stabilization units, otherwise, is that they are not meant for people with substance use disorder. And sobering services are not meant for people with mental illness. And this is just like, this is a thing that characterizes behavioral health services just kind of everywhere. And I see at least one, Dr. Mark Foreman, a professional in this field, probably is very familiar with that, right? Addiction services, mental health services are siloed in how they are paid for. They are siloed in how they are regulated. And so they wind up kind of expecting a much cleaner dichotomy of these two conditions than like is ever the case, because comorbid or co-occurring mental illness and substance use disorder are in fact very common. But right now we don't have good services that are meant to address both at once. And so this is an opportunity for us to sort of push in that direction. We don't have the regulations that create those spaces, but we're putting these two things in immediate adjacency, and over time aim to work to like create a more and more seamless service that really reflects the people who need care, who very often are dealing both with a mental illness and with a substance use disorder. So for folks familiar with El Cajon, this is the property. This is county-owned property, which has been the old assessor's office in the county on Magnolia, on South Magnolia. And so we've been doing a lot of outreach to surrounding areas, been doing a lot of outreach to electeds in El Cajon. To a person, we have heard nothing but emphatic support for this service. I think born largely on the or informed significantly by the experience that communities up in North County have had with crisis stabilization units there, which has been very, very positive. For more information, we've got stuff online. We've got QR codes. Again, I mentioned if you guys are interested in data on how the sites up in North County are performing, I'd be happy to share some of those data with you as well. I'll stop there. Thanks.
All right. Well, thank you very much. First thing I'm going to ask is, and then I'm going to go to the panel, is are you coordinating in any way with that new care court type? Have they even got that thing started yet? I don't remember.
Oh, dear.
Had to go there, didn't
Yeah, had to go there, man. And you're going to kick me out by 3.
Reader's Digest version.
Yeah, not my strong suit, Reader's Digest, as you gather. But Care Court will launch October 1st in San Diego County. San Diego County is a pilot county, so we're doing it in front of most of the counties in the state. Care Court is for a very specific category of folks, just schizophrenia, spectrum disorder, or other psychotic disorder. So a lot of the people who show up at CSUs may have, those diagnoses, and so in that sense, there'll be, there would be some opportunity. The aspect of the sort of profile that a person appropriate for Care Court must also have is that they must not be engaged in care, and they must be resistant to the idea of engagement in care. So it's entirely likely that we would, have somebody on a 5150 in a CSU, and that we would decide that petitioning for Care Court could be helpful. So behavioral health services or the provider, they may petition some people into Care Court, and it may be helpful. Care Court's a funny thing. Happy to talk more about it at some point. We'll be doing more kind of community convenings about it as it gets closer to launch.
That's probably a whole different presentation.
It would be. It's a whole other.
Okay,
but yeah, I'm happy to talk more about it.
Thanks. Well, I can tell you that those of us in law enforcement or former law enforcement are happy with the idea of being able to do a drop-off and not sit around and wait all day.
Yeah, I imagine.
That takes a lot of time and money.
Yeah.
So anybody down here have any questions? I'm going to let Mark go first.
Gotcha. It's been a while since I've interacted with these systems that you're describing, so I appreciate the update.
Of course.
I'm used to dropping people off as a law enforcement officer at detox and that sort of thing. I know things have changed a lot since then, so I appreciate that. What piqued my interest as you were describing this, and the mayor just kind of touched into it, is the ease for law enforcement to do the drop-offs at the CSUs. Mm-hmm. While there's still entities that have to abide by these federal guidelines.
EMTALA, yeah.
So my mind goes to, why do the federal guidelines begin with in the first place? What happened so many years or decades ago that caused those to come into place? And then what safeguards are there to make sure that we don't go back down that road of whatever it was? Because usually when some federal level thing comes in, something horrible happens somewhere and it made its way up.
Yeah.
Whether it's taking care of patients or whatever, because
Yeah.
it's not about the cops, it's about the care for the patients.
Yeah.
Yet, as a community, we need our cops back
Yeah.
on the street, so there's this balance.
Yeah.
And having them sit in the car or sit there doing reports for 8 hours is not good for anybody. It's not doing anything for the patient, because the patient's going to be seeing doctors and nurses and psychiatric teams.
Yeah, that's right.
So there's all of this, but the purpose behind that and then the safeguards to make sure that that doesn't happen here in this county.
Yeah. Great question. I have to say, I don't know the full origin story of EMTALA, but I'm going to Google it on my way home and be happy to get back to you all. I'm guessing lawsuit, and it's, and it, like most things, probably that's part of the origin story, and it's about, it's about risk mitigation. It's about litigious risk mitigation, most likely, right? Not about patient care risk mitigation. But that's, that's the only thing in healthcare like that. No, I'm just kidding, right? It's like so much in healthcare is like that. And there's so many things in healthcare where you're like, who in God's name would have thought of that, right? And often the answer is that's how it's always been. I've just been in conversation about other stuff with the Department of Healthcare Services in the state, and there are really significant things, and they're like, I've asked all the people who've worked here the longest, and all they can tell me is that's how it's always been. So that's part of the answer. I actually feel zero risk that something like EMTALA is going to be widened to include community-based CSUs. I feel zero risk because they work so beautifully in this, and there's just like so much political support, I would say, and momentum behind the build-out of these. Before we started building out this network, I visited a CSU up in Riverside County. They've got one of them, so we really ran with this, but I was incredibly impressed with what I saw up there. One of the data points that they relayed to me is that single CSU was so efficient with law enforcement drop-offs relative to the emergency departments in the psych hospital that had been taking patients, that they estimated that with that one thing, they were saving the equivalent of 37 law enforcement FTE a year, just in all of those accumulated hours. And so, I mean, I just know from talking to all the law enforcement agencies across this county, like there are a lot of folks would be very up in arms if the state did anything to diminish the accessibility of these spaces to law enforcement.
With that could still happen, just because it is a state.
Yeah, no, that's true. Like stupid things absolutely happen. I wouldn't.
Yeah.
I'm
So,
not a stupidity
Mark, was that it,
denier.
or?
Yeah, so as you're describing that, I'm envisioning that, and I don't know if there's data on any of this, that having the law enforcement person out of the picture may be more healing for the patient. Even if they know that they're out of the building, could be enough for them to start to kind of tick down a little bit.
That is our experience, is that when law enforcement's more distal, that people do better with de-escalation. One of the things that we built in tandem with this network of CSUs is a network of mobile crisis response teams. This year, we're, I think, expanding to around 34 mobile crisis response teams across the county. These are non-law enforcement, clinician-only teams that respond, in addition to responding to calls to 988 or to the county's access and crisis line, respond to 911 calls. And the data there are very compelling. About half of all of the responses that the mobile crisis response teams make are driven by 911 calls. So those are calls that are diverted from that would have had law enforcement out on the street chasing somebody down who, isn't going to be benefiting from it, and in fact is at risk of being traumatized by it. And about half of the calls that the mobile crisis response team responds to, they manage to de-escalate without a transport, just like in situ. They manage to sort of stabilize people, get them connected to care without actually moving them anywhere.
Right. Is that it? Well, I'm going to go David and then.
Hi, David.
Hello. I should start off by saying that my agency is funded by the Department of Health and Human Services, Behavioral Health Services, to avoid any.
Too late.
So can you talk us through the spectrum of care on this process? So one of the things I hear often from families who have had a loved one who's experiencing, a psychiatric issue or that is that they feel like it gets to a certain point and then it's kind of dropped off.
Yeah.
And then it becomes the family's responsibility
Yep.
to
Yeah.
fill in the hole there.
Yeah.
And so I'm wondering if in these crisis stabilization units, because it looks like they're just for 24 hours, and we know that sometimes these episodes last beyond 24 hours, kind of what happens if someone has to go beyond that 24-hour, and how is the family or other folks involved in that
Yeah,
process?
that's a great question, David. Well informed. It's like a basic fact of behavioral health that when you involve family or networks of loved ones in care, the effectiveness of care is fathoms better. And so we always want to achieve that. I neglected to mention before that the sort of ceiling on length of stay regulatorily is 23 hours and 59 minutes in crisis stabilization units. Most folks are through in between 4 to 7 hours. In some cases, they wind up staying longer. And that often has to do with there's no place to put them. And they, they need a level of care that isn't, like appropriate for an outpatient program referral, and there isn't a housing resource. So this is the main thing that we grapple with in behavioral health services, is that we got this whole continuum, and it's missing like some of the key parts. And those parts are mostly about paired long-term care and housing at this point. We were missing this, but now we built this, right? And this is really beautifully addressing a lot of what were the pain points having to do with emergency departments. So now, in fact, we have really shifted our attention. I mean, we're obviously still building this out, but we've added, let me say, to the bodies of work that we're really sort of ramping up most aggressively. Huge expansion of long-term, community-based care settings where people really have a sense of home, a sense of life, a sense of purpose and place and where they live, so non-clinical settings. And so we're building those out. That's, some of that is driven actually helpfully by Care Court. Care Court can also potentially help with some of the dynamic that you're describing. It is sort of meant for cases where we anticipate a likely, or maybe a nearly inevitable episode of disengagement. The other thing that we built into the service is a month-long period of ongoing care coordination after discharge. So a lot of the focus, and this is, again, in great contrast to how emergency departments function. Anybody work like for a hospital system here? Oh, thank heavens. So emergency departments really are meant to get people out of the beds and don't have staffing that is meant to develop a relationship and follow a person. But crisis stabilization units are designed in that way. So there's a huge emphasis, as soon as somebody shows up, huge emphasis on identifying what the best place for them to go is afterwards. And then we built into the, how we resource these things, capacity to have care coordinators actually work with people even after they've gone, to make sure that they're in environments that are as good as possible, with full acknowledgement that there aren't enough of those environments right now for everybody who needs them.
Is that it?
Just one other question. So in the Bridge program, is that going to be introducing folks to like medically assisted treatment, those kinds of options?
Yeah, so in connection to the sort of like treatment annex piece of this, that's exactly right. So, and I didn't mention also, I did mention 12 recliners for the CSU, and we're thinking about 10 to 15 cots. That's the furniture that we use to describe the recovery bridge center. So if a person has opioid use disorder, then we would recommend that they engage in medication-assisted treatment. That's by far the most effective treatment modality for people with opioid use disorder. Different for people with methamphetamine use disorder. There are medications for alcohol use disorder, but they don't work as well. There is one that is a depot injection. We can talk more about that later. But opioid use disorder, we would absolutely emphasize medication-assisted treatment.
Great. Bonnie?
Thank you for this presentation. Sure. You may have just answered the question, but I was going to say, how many recliners are going to be at the
12.
opening? And what's your ETA on opening?
What is our ETA at this point? Because it gets pushed around. I think we're talking about 2025. Yes. That's Danya, who has all the answers.
Well, then why didn't she make the presentation?
She should have. She should have. You guys have been.
You're only the director.
You'd be way better informed. So 2025. But it's a funky moment in the economy, right? So, right. But we again, when we were building the CSUs up in North County, there was strident community resistance, and we had to work very hard and very long to get those things established. But now people see, and we have absolutely the most committed opponents of that work are now its most committed proponents. And so...
That's an interesting term to use with the facility, committed.
Yeah. Pun not intended, darn it. I like to intend my puns.
Bonnie, is that it? Steve?
Okay. Yeah.
So I have a few questions. I'm just going to say them. If you forget, ask me, or if we don't have time, that's okay too. You just mentioned a kind of a funky time in the economy. How does funding relate to geographical location choice? How do you determine where there's a need to set up these centers? And is it some that hospitals are convenient locations, so you start there instead of finding real estate?
That's a great question. Depending on zoning, conditional use permitting, stuff like that, right? Where we've experienced delays, it can be advantageous to do this on county property. That's part of why we're doing this on county property. There are advantages to doing this in settings with high Medi-Cal density because those are populations that are disproportionately vulnerable. And we, again, are the health plan for people on Medi-Cal. So that kind of makes El Cajon make sense, and I would say that's generally a good rubric, though it does not mean that they don't also make sense in settings with lower Medi-Cal density, right? Because these are services that we know, they treat all payers. These are not Medi-Cal specific services. They are funded currently through cost reimbursement contracts that we hold with providers. That is shifting. We're in the midst of some wacky payment reform stuff with the state. I don't want to take the state's name in vain again, but there will be some challenging transition points, I think, just administratively, but I feel very confident that this service category will do well in the context of payment reform. It's basically shifting from a cost reimbursement to a procedure-driven fee-for-service system, if that means anything to anybody.
And you also mentioned two types of staffing, and the second type you mentioned, I think you called peer support providers. Mm-hmm. What sort of training do those people have? And is it hard to find staffing for this type of facility?
It's hard to find staffing for any type of facility in behavioral health right now. But this may be one of the less difficult categories of staffing to find. So the state has just passed legislation in the last year or two enabling people who fit this category, peer support providers, to participate in public insurance drawdown. So their work is funded through public insurance revenue, and it wasn't ever before. In order for peers to do this work and draw down that revenue, they need to be certified, which means they need to go through a training that lasts some weeks and then pass an exam. That is being for people in San Diego County, all organized through a body that is statewide called CalMesa, which is a joint powers authority in the behavioral health space. The key aspect of peer support work is that it's based on lived experience, as you would gather from the word peer, right? So the emphasis is less on clinical training than it is on training people who have experience as service consumers themselves, often, training them how to best use that in ways that will be helpful to other folks. And a lot of it is just like basic human stuff, frankly, right? Express your empathy and talk about how you have had similar experiences. That there is just a lot of magic in that for people with behavioral health conditions. It pays huge dividends for care engagement.
And last question, you mentioned at the beginning that part of the goal was that ERs are a not good but best case scenario, and they just try to get people in and out real quick. Worst case scenario is they just get discharged after a law enforcement contact or from the ER. How does the system measure success? What are you looking to change in the system, and how can you say this is working or things need to be changed?
Yeah, it's a really great question, and in lots of different ways. There are many sets of process and outcome metrics that we use to sort of gauge our work, and I would have to say we're really still developing more sophisticated capacity to do that than has traditionally been available in San Diego County. The traditional way of thinking about behavioral health work has been program by program. Is this program doing everything that it's contracted to do? Is it seeing as many people as it's contracted to see? We now want to function much more like a real health plan, which we have statutory obligations to do. And that requires that we look at people, specific people, and their longitudinal trajectories through care over time to see, okay, you had this engagement in a crisis stabilization unit. What happened to you after? What happened to you within the first month after? What happened to you within the next 6 months? What happened to you for the full year after you were engaged with a crisis stabilization? What we know from the broader literature is that crisis stabilization units divert as many as 70% of cases to adjacent emergency departments. So people who work at Grossmont Hospital, for example, the emergency department, are very pleased that we're establishing a community-based CSU so close to that. Grossmont has a famously very busy emergency department with lots and lots of behavioral health in it. It'll still get a bunch, I'm sure, but I anticipate seeing a discernibly reduced behavioral health volume at Grossmont because of the establishment of this service. And then we do expect to see people doing better over time than they would. We expect reduced rates of disposition into inpatient care. So you take the same, 2 comparable cohorts of people, send them to one cohort to an ED, the other cohort to a CSU. We would expect much higher rates of disposition to inpatient care from an ED than a CSU. CSUs are going to help people avoid going into inpatient care. So we aim to see reduced inpatient bed stay, and that's just good for the whole system. Because right now, of course, we hear a lot of clamoring for more beds, more capacity. What are we going to do with all these people? Part of why we have that clamoring for more capacity is because we've got systems that perpetuate service utilization without getting people better. It's just kind of one, nefarious cycle after another. And so what we're trying to do is, instead of just building more stuff that's going to cycle people through, we're trying to build different stuff that will create different trajectories over years.
Anybody else? Kristen?
Hi, sorry. So in regards to kind of what you were just speaking of in measuring success, even kind of to piggyback on his last question there, and you're discussing a lot of interaction that you're having with ERs, and I'm sure that you can only speak to this in San Diego County, but we're seeing statewide that there's a lot of pressure. You discuss a lot of law enforcement, but we're seeing a lot of pressure for EMS to reduce wall time that exists, so that's transfer of care, essentially. With AB 40, we've seen that coming down a lot. Asking for a requirement of a mandate of a 30-minute transfer of care, it seems to be unreasonable, right? And it's not heavily supported at this point. So with all of these CSUs popping up, and maybe some of these statistics that are coming out with reduction of services at an ER room level, are we seeing any of that that's being discussed amongst maybe EMS agencies as well? Are they seeing a reduction in wall times because of it, because there's maybe more availability at said emergency room or anything like that? And I know you can probably only speak to this countywide, but this is a problem statewide.
I can't even speak to it the way I would want to countywide because I haven't asked. So I don't have those, I have neither the quantitative nor qualitative data, and you're kind of asking both. But I'm very interested in getting it. It's a really good question. We absolutely are hearing anecdotally about reduced ED volume, and then we're seeing in some of our LEMSIS data that those numbers are actually going down. This is a kind of thing, given the sort of nascency of this system generally, that we have to see over more time, right?
Sure.
It hasn't been there long enough for us to say.
I was going to ask that next.
Yeah, well,
what the time frame looks like on how these have been operational.
That's right. I mean, the thing we can't control for are differences in the general wellness in terms of behavioral health, right, across the population. We need to be running this for more time to say it's having this impact irrespective of changes in overall rates of, depression, anxiety, and psychosis. And we just haven't been running it long enough to be able to discern that. But the questions that you're asking about, sort of immediate impacts for for EMS are ones that I'll absolutely take back to the ranch, and we can sort of figure out how to bake into more sort of near-term evaluations.
Yeah, I would just imagine that it would impact our Santee Fire Department immensely because, like you're saying, having East County services available could then reduce, potential wall time at places like you're
Should.
saying, medical facilities
It
such as
absolutely should.
Grossmont and
Yep.
and so on. So it would
should.
be a positive impact, I would think, for us here as well.
That's what we would anticipate, yeah.
And then lastly, sorry, how can we support the county in this endeavor?
Well, this is a great example of it. I mean, I think, taking an interest, we expect most of the people transported to be from El Cajon, but this is not a law, agency-specific initiative. So I think, taking an interest in the adjacency of this resource to the community of Santee is important. Contributing to the overall shift in how this stuff gets talked about, right? From liability to asset is maybe the most important thing. And in the past few years, as I've been doing this work, I've seen that shift happen really significantly. When we were working this stuff in North County, these things were just anathema. It was as if we were dumping toxic fluid or something in the middle of a schoolyard. It was just nothing worse could possibly happen. And that's shifted, as I mentioned before. But the stigma that's associated with mental illness and efforts to give mental health care is very stubborn. And so just contributing to that, shifting the language, shifting the thinking that is still prevalent, that paints this kind of resource as a liability instead of an asset, I think you all are in really powerful positions to help address.
All right, well, thank you very much. 3 o'clock, I gave you an extra minute.
Oh, I appreciate that. Thank you guys so much.
Watch out for the trapdoor opening.
So, very interesting. We'll have you back when, maybe for some updates in the future, if we can do that, to see how it's coming along, so. All right, that takes us to item number 5. Who's doing that, Linda or Marlene?
Okay, I'll speak to that. We have had a city staff collaborative kind of meeting with a special events team as well as our marketing team and Marlene participating as well. And we are in the beginning stages of planning a past, present, future. We haven't nailed down the title yet. Event at the Santee Historical Society in the springtime. So preliminary information, we just kind of gathered a lot of thoughts and we will be moving forward with some additional planning. The more things get solidified, the more you'll be updated.
Great. Any questions? David?
Idea that just popped in my mind. Are we putting a still on the TV, Santee TV, our community values, and is that something we could do?
Yes, I believe that is still part of the plan, and we do have the placards in front of all of the city counters, and the budget that just is ready for publication on our city website is set up with a whole section about the community values and how the different departments are doing things to help support those. So yes, we are still moving forward with that.
Linda, did you have something?
I had a question with regard to the event coming up in the spring. To what degree will you be inviting other individuals to be part of your planning committee, possibly?
It's not a possibly, it's a for sure. We just needed to get our own staff concepts together and look at the logistics to see what opportunities were there. But we do understand there is a core group of individuals, specifically a part of this committee, who very much would like to be participatory in that. And yes, you are on the list, so you're not out of it yet. So we're going to keep you involved.
All right, any other questions or comments? Thank you. Takes us to communication from committee and staff members. Anybody have anything? Mark?
Mayor, you opened the meeting with remembrance for 9/11, and it was striking me today with all the remembrances I've been seeing through social media and whatnot is, what about September 12th? So often we remember, but we forget to pay attention to what we brought forward because of it. And with community healing, individual healing, we're talking about mental health here today, that aspect is, okay, this thing happened on September 12th, how did our lives change? That's the bigger remembrance, is because the world changed that day. So now, as we remember, tomorrow when you wake up, what have you brought forward with you because you remembered today? Whether it's the lost ones or the changes in life, lifestyle, whatever it is, putting meaning to it so it doesn't go meaningless. And it doesn't matter whether it's 9/11 or the Holocaust or some traffic accident that you drove by or that you were involved in. It doesn't matter what the event is. When we remember it, if we can put meaning to it as we pull it forward, it heals the memory so that we don't forget, so we can remember. So I just wanted to bring that up in a setting here, and then just see how it goes with the rest of the day and tomorrow and next week and 20 years from now as we remember.
Thanks for bringing that up. Anybody else? Anything? Bonnie?
Thank you. There were some handouts that just went out. I wanted to share with everyone. This Saturday, the San Diego River Park Foundation is doing their fall 2023 homelessness census count here in Santee. And all are encouraged and welcome to join the East County Homeless Task Force team bright and early at 6 a.m. You'll get your steps in, go out and see what's going on in the riverbed, and assist with their, I think they do it 3 times a year count. So it's kind of like the point in time count, but through the River Park Foundation, apologies. So there's information about how to sign up on that flyer. And then secondly, one of CASA's initiatives for housing advocacy and service information for City of Santee and other neighboring communities are these pocket guides of resources for community members. We also have a website called ecassist.org. Now, this pocket guide has not been updated for about four years or so. So I would welcome if anybody knows of any changes, has any additions, deletions, to please share that information with me through the email that's given with the little flyer that went along with that. The sheriff has already reached out to me, somebody with the sheriff's department, to share some updates for modifications to sheriff information. So thank you.
Thank you. Anyone else? Great. We'll move on to item number 7, communication from the public. Any speaker slips?
Yes, sir. We have one speaker slip for truth. 3-minute time limit.
Okay, this is Truth. I'm here to flip greedy Luke Bergman's pyramid scheme. He's so greedy, he's trying to expand the county's behavioral health beast into Santee. Let me quote one of his bosses, Nora Vargas.
Not under my watch, no.
And that's the clean version, of course. But first, I'm going to give the advice, don't ever compare 9/11 to the Holocaust. You're going to get yourself in a lot of trouble. Now, the county of Bergman wants to add 18,500 employees just in behavioral health. That would double the size of county government. And they have to justify that expansion by selling their garbage here and everywhere else in the county. But what do they sell? Harm reintroduction for adults and children alike. That means needles and pipes on the taxpayer dime. They don't care about addiction. They actually enable it. There's also electric convulsion shock mistreatment. And the county has a screening to care initiative and control to mentally test children and provide them with drugs while in school without parental knowledge. And now the county's gone from pushing over $1 million prison beds to billion-dollar prison spas. That's what Luke Bergman brings with him, so all his recommendations should be rejected as they are based in harm and lies, as evidenced very clearly by the anti-science extremist 2020 lockdowns. That's why suicide is the second leading cause of death for 10 to 24-year-olds, and why there were over 364 deaths by suicide in 2021. And with psychological despair up by 500%, as he said. So when Luke said responsive to, he meant the cause of, because the county is the real crisis. So I recommend keeping county government and all government out of people's lives. That's how we prevent suicides. So now the county's gotten its butt verbally kicked in Bonita and in Santee. And hopefully my friend Nora won't cry about it this time like she did at BOS. Or maybe I should say, hopefully Luke won't cry later to Nora. It'd be pretty weird because we actually all get along. Now, regarding the last meeting, I heard about a small event next year in April, right, to be held at the Historical Society. Marlene mentioned representing different languages spoken and different cultures, similar to the Balboa Park International Cottages. The problem is Santee is not downtown. It's not going to have that diversity or that internationalist mindset. So it's important that everyone is being authentic, like the city mission values say, or it's going to come across as artificial. So any type of Santee or historical preservation forward future festival needs to reflect what is unique about this city, not a copy of other areas. Keep the personal DEI agendas out of it is what I'm saying. Let the community represent itself. Bring in old-time history experts, local business, children's perspectives, and forget what language they speak. It's probably going to be English anyways. And another issue I heard is that it's going to be at the Historical Society, and if Santee likes their small events, like Bree said, might not be enough room. But luckily, there's plenty of time to figure it out.
Thank you. That takes us to item number 8, which is our next meeting, and that's going to be October 9th, 2023. And the topic is going to be xylazine. Xylazine. Easy for me to pronounce. Whew. Yes. Yes.
I just want to remind everybody that September is Recovery Happens Month in the state of California, which the goal of that is to remove the stigma of addiction. That's culminated on September 30th with the Walk for Sobriety at Liberty Station. That's a gathering of people who are either in recovery or seeking resources for addiction, and we hope that it's well attended by the public. Everyone is invited.
Great, thank you. So our speakers at that next meeting are going to be James Fontaine. He's the Division Chief of the Major Narcotics Division of San Diego County District Attorney's Office. And then the December 11th meeting will be a cancellation. There will be a lot of people out of town and stuff and not available that day. So having said all that, I don't see anything else. That,
Are we meeting in November?
yeah, that's...
Okay.
Sorry about that. All right. That takes us to meeting adjourned.